Hey YouTube, welcome back to my channel. My name is Dr. Daniel Kaplan, and my mission is to make psychology accessible to all. In the past few videos, we talked all about eating disorders, things like anorexia, bulimia, and binge eating disorder. However, we also need to talk about the concept of feeding disorders. And in today's video, we're going to explain the difference between eating disorders and feeding disorders. And then we're going to go into three very common eating disorders. And then we will also talk about another feeding disorder / eating disorder that is a catch-all. So without further ado, here we go. So as I mentioned, in the DSM-5, it does include several eating disorders and several feeding disorders. And the first thing I want to do is make a distinction between the two. Eating disorders, usually the disordered eating is due to some kind of poor coping mechanism. And we see that the onset of the condition is frequently in the teenage years and in adulthood. That, in comparison to feeding disorders, is usually feeding disorders are due to some kind of food preference or perceived intolerance. You might hear a person say, oh, the child's very picky when they're eating. And we see these feeding disorders occur much earlier, such as in infancy and childhood. So what is important to understand is that you can only receive one feeding or eating disorder at a time, because the feeding disorders have something called a rule out, an exclusionary criteria for if it's an eating disorder, and vice versa. The only exception is Pica, where a person can have Pica plus and another feeding or eating disorders, assuming that the Pica behavior is clinically significant enough to warrant attention. So let's talk about ARFID. ARFID is a reconceptualization in the DSM-5 of what we previously called a feeding disorder of childhood and early, of infancy and early childhood. So what are the characteristics? One, we see an apparent avoidance or lack of interest in food based on some kind of sensory characteristic of the food, such as texture, taste, and it creates some kind of aversive consequence. So what happens is the person avoids eating because they don't like the texture, they don't like the taste, etc. And that causes at least one of the following problems: significant weight loss. So you might hear the term failure to thrive connected to ARFID, a significant nutritional deficiency, the need for oral supplements, and it interferes with some kind of psychosocial functioning. So the dysfunction component of all disorders are there. Now, we also, like I said, we use rollouts. This disturbance cannot be explained by some kind of culturally approved or sanctioned practice. So if this is considered appropriate within a culture or religious community, then that's not considered ARFID. That's practicing one's tradition. We also, like I said, need to eliminate the possibility or exclude the possibility of this occurring during an eating disorder such as anorexia or bulimia. And ARFID, there is no real body image or weight disturbance connected to it. So if you remember, I said you can only have one or the other. That's a very good example how we exclude the diagnosis of ARFID if there is an eating disorder present, and vice versa. And we also say that the condition cannot be better explained by some medical or psychological disorder. Now, there are conditions such as being on the autism spectrum, having an intellectual disability that have higher rates of ARFID, as well as other feeding conditions. But that's why we specify it cannot be better explained by some other physical or psychological condition. So that's ARFID. Let's talk about pica. So pica is when a person eats non-nutritious substances, right? So if eating things like paper or soil or wood chips or clay or glue or any other thing you could think of that has no nutritional value. And the person has a consistent pattern of eating this for at least 1 month. And we have to, as a second criteria, make sure that what they're doing is inconsistent or inappropriate with their developmental level. And because of that, we recommend a minimum age of 2 years old for this diagnosis, because infants tend to put things in their mouth naturally without any kind of thought. So if they're putting something in their mouth and eating it under the age of 2, they're probably not doing it as a disordered eating practice. But by the age of 2, we become aware that we're not supposed to put non-nutritious stuff in our mouth, and the criteria of pica starts to be met. We also, again, same rules apply. It cannot be due to some culturally supported or socially normative practice. If it's culturally appropriate, it's not a disorder. And when it comes to this condition, it cannot be better explained by some other mental or medical condition. You'll see that this pattern over and over and over, that there's an exclusion if it's due to some other condition. Now, the prevalence of pica, we don't have good numbers. And I'll say that about all of these feeding disorders. We don't really have good numbers on how frequently they occur. Now, rumination disorder. Rumination disorder is the repeated regurgitation of food, and that has to occur for a minimum of 1 month, similar to all the other feeding disorders. And what we see is that a person who is engaging in rumination disorder will chew, swallow partially digested food, bring it back up without forcing themselves to throw up, and then they'll re-chew it, re-swallow it, or spit it out. And this regurgitation has to be an ongoing issue. So we see it typically several times a week, but more frequently than that, it's not uncommon for it to occur daily. Once again, this condition cannot be better explained by some kind of medical condition. It cannot be linked to an eating disorder, things like anorexia, bulimia, binge eating disorder, or ARFID. You can only have one feeding or one eating disorder at a time, as we mentioned, right? So criteria C is going to eliminate this diagnosis if something else is present. We also have to be mindful that it cannot be better explained by a feature of another psychological or mental disorder or another physical condition, right? So things like an intellectual disability or autism spectrum disorder. This cannot be the reason why the person's regurgitating their food. And that is the 3 real feeding disorders. But we have an additional one is kind of like a catch-all. The previous diagnosis used to be referred to as eating disorder, not otherwise specified. So this condition is when you didn't meet the full criteria for another disorder that we talked about. You would get this diagnosis. So the DSM-5 now refers to this as OSFED, or an other specified feeding or eating disorder. So you don't meet the full criteria of one of the eating or feeding disorders that we talked about earlier, but something's going on. So let's look at the 5 examples of an OSFED. So what happens if a person has a case of atypical anorexia? So what is the atypical case? So the individual meets the criteria of anorexia and has sustained weight loss as a result, but they remain within or above the weight range that's considered normal for their height or gender. So they're underweight, they have the body disturbance, distortions in body image, but they didn't fully meet the criteria of being sufficiently or significantly underweight. So that would be an atypical anorexia. We also have bulimia of low frequency or limited duration. So this is an individual who meets the criteria for bulimia, with the exception that they engage in binging or compensatory behavior less than 1 time per week. And if you go back to my earlier video, the form of bulimia, you have to have, even for a mild form, at least 1 binge per week. But this person has had fewer than 1 binge or compensatory behavior per week, or the duration is shorter than 3 months, which is the duration expected for eating disorders. So if this occurs, you have some of the features of bulimia, but you're not meeting all of the criteria. So we need to have some diagnosis for you so we can treat you. A third example of an other specified feeding or eating disorder is binge eating disorder of low frequency or limited duration. It's going to be very similar to bulimia. So this person meets the criteria for a binge eating disorder, except they're not averaging more than 1 binge per week, or the symptoms are fewer than 3 months. So notice how if you're not meeting the average binge or the length of time, that's a binge eating disorder of low frequency. So that would be OSFED. Same thing with bulimia, right? So it's either the duration is not being met or the frequency of the behavior is not being met. Then we have purging disorder. A purging disorder is a condition where a person engages in purging or self-induced vomiting, laxative use, but they're not engaging in binges, right? So you can't diagnose this individual with bulimia because it's supposed to have a binge and some form of compensatory behavior. So what do we do if a person is just purging but not binging? So we would give them an OSFED and specify that it's a purging disorder. So they're just purging, using either vomiting or laxatives, something like that, but they're not binging. And then there's this other condition which we're trying to understand. We don't have enough information on it, but there's something called night eating syndrome, which is the final of the 5 examples of an OSFED. And this individual has recurring episodes of eating after waking up at night or eating excessively after their evening meal. So this person kind of takes to the refrigerator in the middle of the night. And these examples of night eating cause problem or distress, and that's what we call night eating syndrome. So notice that the DSM-5 modified the terminology of eating disorder not otherwise specified, but they gave it a little more teeth to try and explain the examples of when you would get these particular OSFEDs. So I hope this was useful. If you found this video useful, hit the like button, subscribe, click the notifications tab. I need your support. By doing so, it will bring this video to a larger audience. And if you have any questions or comments, write them below. I read every comment, I respond to every comment. So Take care, everybody. Till next time.